This is a technique video describing a single-stage primary anterior cruciate ligament reconstruction with slope-reducing anterior closing wedge proximal tibial osteotomy and a lateral extra-articular tenodesis. Shown here are the senior author's disclosures. The patient is placed in supine position on the operating table and induced under general anesthesia. A Lockman and pivot shift exams are performed to confirm the clinical findings. An anterior incision is made from 6 centimeters proximal to the patella to 6 centimeters distal to the tibial tubercle, exposing the entire extensor mechanism. Dissection continues medially over the medial joint line and laterally over the iliotibial band. The exposure for the closing wedge osteotomy is then made by elevating the lateral periosteum and the tissues just above the anterior compartment proximally for 1 centimeter, continuing between the lateral aspect of the patellar tendon and the anterior proximal tibiofibular joint. Medial dissection starts at the MCL and continues to the patellar tendon, proximally elevating 1 centimeter layer of periosteum and clearing under the patellar tendon so it can be later retracted. Next, a spinal needle is placed at the proximal pole of the patella and a full thickness 9 by 1 centimeter quadriceps tendon autograft with a 10 by 20 millimeter patellar bone plug is harvested. The harvest site is closed with suture and the quadriceps tendon autograft is prepped for passing on the back table. Dissection is carried laterally, exposing the ITB, and an 8 by 1 centimeter strip of the inferior third of the ITB is harvested for the LET, leaving it attached to Gerdy's tubercle. Q-fix anchor is placed midway between the anterior aspect of the fibular head and Gerdy's tubercle, 1 centimeter distal to the joint line at the tibial attachment site for the anterolateral ligament. The LET graft is fixed at this point. The femoral attachment for the ALL is identified 5 millimeters posterior and proximal to the lateral epicondyle and is marked for later placement of a Q-fix. Anteromedial and anterolateral portals are now made and the joint is insufflated with normal saline. Assessment of the suprapatellar pouch and interarticular compartment follows. The ACL tear is identified and debrided and a burr hole is placed midway between the anteromedial and posterolateral bundles of the ACL. A guide pin is placed and then over-reamed with a 10 millimeter low profile reamer to 25 millimeters, maintaining a 2 millimeter back wall. A passing stitch is then placed. The arthroscope is inserted through the intercondylar notch and a probe is used to palpate and confirm the meniscocapsular separation of the medial meniscus. A rasp is used in the inferior and superior margins along the length of the tear and 7 inside-out vertical mattress sutures are placed to secure the ramp tear. The lateral meniscus root tear is identified and the tibial root attachment site is then decorticated. 2 cannulated pins are drilled from the anterolateral tibia into the decorticated root attachment. The straight mini first pass is used to place 2 ultra-tape vertical mattress sutures into the lateral meniscus root tear, which are shuttled down through the cannula for final fixation following the osteotomy. The ACL tibial footprint is now identified and outlined adjacent to the anterior horn of the lateral meniscus, and a guide pin is drilled using an ACL guide. This is over-reamed with a 10 millimeter acorn reamer, ensuring the apertures are clean for graft shuttling. 2 guide pins are placed perpendicular to the tibial shaft on each side of the patellar tendon just above the tibial tubercle. Fluoroscopic imaging is used to confirm pin position. An additional 2 pins are placed proximally at a trajectory where the pins converge and meet at the posterior cortex of the planned wedge resection at the other pin pair. A bovie is used to decorticate the planned resection laterally, and a small ACL saw blade is used to cut out the cortical wedge for the osteotomy. The same for the medial side follows. A curette is used to sufficiently clean the cancellous bone posteriorly, which is confirmed fluoroscopically. The osteotomy is now closed by hyperextending the surgical extremity carefully. Fixation occurs with 3 large Richard staples, 2 medially, 1 laterally to secure the closure. This was confirmed fluoroscopically, and we noted the patient's Lockman test was now 1+ compared to 3+ preoperatively due to slope reduction. A 10 millimeter reamer is then hand-driven up the ACL tibial tunnel to clear the tunnel aperture for future graft passage. The ACL graft is now passed into the femoral tunnel and is fixed with a 7 by 20 millimeter titanium interference screw. The lateral posterior root is now fixed under direct visualization on the tibial cortex with an endo button. The ACL graft is now tensioned in full extension and fixed to the tibia with a post and washer. The arthroscope is reinserted into the joint to confirm the ACL graft is taut without impingement. The LET graft is now fixed to the femur using a Q-fix anchor with mini tape at the previously marked location of the ALL anatomic femoral attachment. Fixation occurs with the knee in 20 degrees of flexion and neutral rotation. Deep and superficial tissues are closed with O and 2 ovicryl, and a monocryl stitch is used for the skin.